the Mayo Clinic has been running some of the first human clinical trials for Senolytics. What is the most important thing that you've learned so far that you think people should know?
Yeah, so I think, perhaps I can put that in the context of what we learned from our clinical trial, which was published a little over a year ago. There had been a number of clinical trials, primarily using the combination of drugs, dasatinib and quercetin, which I'll refer to as D plus Q. Dasatinib is a drug that's actually FDA approved for certain diseases, certain hematologic and rheumatologic diseases. And quercetin is actually a flavonoid that is widely available. But at least in cell culture and in mouse models, intermittent administration of D plus Q seemed to be effective in ameliorating a number of age-related pathologies or improving a number of age-related pathologies in mice. And we had done some previous work in mice showing that if we gave D plus Q just once a month, that could prevent age-related bone loss in mice. So we published that study about 7 years ago, and it took us 7 years, to get all the initial approvals, and then, we had to deal with COVID, which delayed a number of these clinical trials. So finally, 7 years later, we were able to publish the first randomized control trial and the largest randomized control clinical trial of control subjects versus D plus Q. And this was a reasonably sized trial, 30 participants in each group for a total of 60 participants. Because osteoporosis is more common in women, we studied post-menopausal women all over the age of 60. And this was a kind of a proof of concept 20-week or 5-month study where the D plus Q was given once a month for 5 months. I think one important point is that what we're learning from the preclinical animal models is that senolytics don't need to be given continuously. That very intermittent administration appears to be effective. And this has to do presumably with the fact that senescent cells take weeks or longer to accumulate. So it's kind of the hit and run hypothesis where you just intermittently reduce the burden of senescent cells and still see biological benefits, at least in mice. And that gets around some of the potential toxicities of these drugs because you're giving them very intermittently. So we gave the intermittent D plus Q. And because my primary interest is in skeletal aging, we were looking for a skeletal response as kind of a biological signal. So this was a very early kind of first in human translational study. And we just wanted to know, could we see a biological signal for efficacy? And for that, we measured in the blood certain markers that we can measure for how rapidly bone is being broken down and how it's being formed. And in the overall group of women, we saw a modest signal for an improvement in bone formation. Now, that signal was there, but it was nothing to write home about. But it's important to note that prior to the study, we had hypothesized that the skeletal response to the senolytic would depend on the initial senescent cell burden, i.e., we had postulated that women with a higher senescent cell burden might have a better response to the senolytic intervention, which is a plausible hypothesis. So we had used a specific measure of senescent cell burden in peripheral blood. It's called the T-cell P16 assay. I won't go into the details, but based on that assay, when we stratified the women into what we believed was the highest tertile for senescent cell burden versus the lower two tertiles, what emerged was that the women in the highest tertile actually were driving the overall response. So they had a much more substantive improvement in bone formation. And then subsequently, we were able to develop a set of blood markers that were easier to measure, a so-called SASP score. SASP stands for senescence-associated secretory phenotype, which is elevated with or factors that are released by senescent cells. So the women that were in the highest tertile for the SASP score also exhibited the most robust responses to the Senolytic. And then there was a subset of women that were high on both measures, and they exhibited the most robust responses. So we went from, just to put some numbers on it, in the overall group of women to about a 16% improvement in bone formation to when we selected the highest tertile, either based on the T-cell assay or the SASP score, to about a 35 to 38% improvement in bone formation, to when we looked at women who were high on both measures and presumably had the highest senescent cell burden, there was a 60% improvement in bone formation. So using this method, we were able to identify a potential group of responders that really, I think, sets the stage for future trials. And the message, is perhaps not surprising, but we kind of draw the analogy to what's happening in cancer medicine, where the particular drug that's used in a given individual with a given cancer is more and more based on the molecular changes that are occurring in that cancer, the so-called, personalized therapy for cancer. And we believe that aging is perhaps very similar. There are at least 13, if not 4, distinct aging mechanisms, and senescence is just one of them. So what our study would point to is we need to identify whether senescence is a key driver of aging in that particular individual, because we believe that those would be the individuals most likely to respond to a senolytic intervention. And there may be other individuals who need other types of interventions to delay aging and not necessarily senolytic drugs. So based on this hypothesis, we're now planning a larger trial to more directly test this idea and look beyond the skeleton, look at measures of frailty, cognition, immune function, cardiovascular function, kind of across all measures of health span. Because, as I say, our initial study was really just looking for a biological signal. Now we want to expand this to more, concrete measures. So I think that's kind of what we learned from our trial. Now, to step back, the overall field, there are many, many trials of senolytics. D plus Q, fisetin, which is a flavonoid, is also being tested. There have been trials published where more toxic senolytics, so-called BCL-XL inhibitors, which can't really be given, systemically, but they have been used for using local injection into the eye for a condition called diabetic macular edema, and they do appear to be effective there. So I think people are pursuing many different directions, all the way from kind of a total body treatment, systemic treatment using drugs, to local injections into the eye. But I think the underlying principle that we've learned from our study is that as we interpret these trials, many of them may be negative because they may not have stratified appropriately for the people with a high senescent cell burden. So it just highlights that going from mice to humans is not simple, that there are going to be many stops and starts. And I think our trial is just an example of what we learned and how, it wasn't the definitive trial, but we learned a lot from it, and how that will inform future trials, both by our group and other groups.
So the women had very kind of varied levels of senescence. And the two tests you were doing are basically trying to measure the same thing, which is the systemic level of senescent burden, right? But they're just doing it in different ways. Would that be correct?
They're complementary approaches. One is harvesting blood cells, T cells, and measuring the expression of a particular gene, P16, in those cells. And it turns out that that is correlated to these blood protein measures that we've identified, the SASP score. So they're interrelated, but it appears that either could be useful in identifying the women with a high senescent cell burden. Now, clearly, the SASP score, which is just based on blood measurements of proteins, is much easier to do than the more cumbersome T cell assay. And the other point I'd like to make is that, we studied women over the age of 60. And it turned out when we looked more closely at these women that, and this was mainly using the T cell assay, that the women who had a high senescent cell burden, i.e. the highest tertile for the expression of P16 and T cells, they were all above 70 years. So it appeared that you really don't get high senescent cells, at least in otherwise normal aging women, until after age 70. Now, the converse wasn't true in that we had, more than half the women who were above 70 were still not in that high T3 group. They were in the T1, T2 group. So it says basically to us that to have a high senescent cell burden, you likely need to be above 70, but you could be above 70 and not have a high senescent cell burden. And that could be due to the fact that maybe you're a healthy ager, you're just aging really well, or that you're still aging, but it's not due to senescence. There may be other mechanisms that are driving aging in that particular individual.
Was there any way for you to tell without looking at the blood? I mean, I know because it's a study, you need to look at the blood, you need to have this detailed analysis. But was there anything else that you could look at and say and estimate whether a person would have a high senescent burden or not?
So we haven't looked at, we didn't really do a very careful kind of clinical evaluation of these participants, other than, screening them for cancer or other diseases. And they were otherwise community dwelling, reasonably healthy older women. So the only thing that emerged was age. So, age above 70 was something that enriched for these women with the high senescent cell burden. Now, in future studies, we plan to do a much more detailed clinical phenotyping of these women. For example, did they have greater frailty in some way? Did they have other clinical features that might, identify these women as potentially having a high senescent cell burden? So right now we're relying on these blood biomarkers, which I still think in the end are going to be the most reliable measure, but we're trying to find clinical correlates for those.
Are you aware of any commercial test that people could take to estimate senescent cell burden?
There is a company I believe it's in North Carolina, that, and I'd have to look up the name, but they do offer.
Ginfinity? Is it Ginfinity?
I can't recall, but
okay.
They will measure the T cell P16 levels for you. Now they use we modified the assay that they're using because it worked better in our women over the age of 70, but they're related measures. But that's the only kind of commercial entity that I'm aware of that, right now will give you some measure of senescent cell burden.
Is there any other way? Is there any way of telling whether a person has high senescent cells?
At this point, unfortunately, I would have to say not in a reliable way. We know risk factors. So we know that, as I said, if you're older, particularly above age 70 from our cohort, obesity tends to increase the burden of senescent cells. Smoking tends to increase the burden of senescent cells. We know people who have received chemotherapy, at least for some time after that, may have a higher burden of senescent cell, and probably chronic HIV infection appears to be perhaps related to an increase in senescent cells. Those are kind of the risk factors, but having a reliable way to identify those individuals is, I think, an important need for the field, both for identifying participants in clinical trials, but also potentially for over time, once they're validated, for general use by the public who are maybe interested in knowing another measure of aging in addition to what's currently available in terms of some of the biological clocks that are out there and so forth.